Which of the following best describes the etiology of this patient's oral lesion? So, a 38-year-old woman with a history of HIV infection presents to the clinic with a 2-week history of white, painless plaques on the lateral borders of her tongue that cannot be scraped off. She has been compliant with her antiretroviral therapy, and her most recent CD4 count was 200 cells. The patient denies any difficulty swallowing, oral pain, or recent upper respiratory infections. On physical examination, the patches are non-ulcerated and have a corrugated appearance, which the following best describes her oral lesion. Okay, so has a history of HIV, 2-week history. It's white, it's painless, lateral borders, it cannot be scraped off. So when I see cannot be scraped off, it's not Canada because Canada can be scraped. So rule that one out. So our CD4 count is 200. So I've seen off of just remembering off of step one, usually less than 200 is like not that great. So the fact that she's at 200 is okay. So we'll keep that in mind, but keep going. No difficulty swallowing, no oral pain. So no recent upper respiratory infection. So usually I feel like with EBV, that kind of comes with like pharyngitis or some kind of upper respiratory infection.
Okay, so talk to me about if you were to give me a diagnosis here, what would the diagnosis be? So just from kind of the first sentence, as you already know, is kind of like the chief complaint, right? You have a middle-aged woman, HIV, so you know that she's immunocompromised. She has a 2-week history, so it's relatively chronic, right? White, painless plaques in the lateral borders of the tongue that can't be scraped off. What do we call that?
Um, not,
You remember
oh,
something called? So remember,
hairy,
say yeah, yeah. Go ahead. That's it.
hairy leukoplakia.
Yeah, there we go. So likely hairy leukoplakia. So do you know what that's caused by any chance?
EBV.
Oh, okay. All right.
The one that I said it wasn't. Yeah, EBV.
Does it make sense? Kind of, I want you to think about the diagnosis first. Okay. What ends up happening is sometimes when I think you're looking at this very clinically, like, well, you're like you're piecing it together, right? You're saying these are the symptoms, these are the labs, right? You're putting the picture together well, but you're skipping one step, and that step is kind of calling a diagnosis first. So I want you to focus on calling a diagnosis first because it'll lead you to the answer. Because if you start crossing out, then instead you're kind of working slightly backwards, if that makes sense, right? You're like, oh, it can't be EBV because usually they have, some kind of upper respiratory thing, right? Herpes. You might say, oh, they have to have some kind of sexual history. So you're working backwards, right? And so you're trying to fit an answer to the question rather than saying, hey, this is my diagnosis. Let me find an answer that supports my diagnosis.
Yeah. Yeah, I
Okay.
got you. Yeah, that makes sense.
Okay, so does it make sense? So like herpes, that's going to be vesicles that are painful. Human papillomavirus that can lead to squamous cell carcinoma in the oral pharynx, right? Um, Pemphigus vulgaris, right? That's going to be kind of your skin and mucosa lesions that like to slough off, right? So it doesn't really, fit here. So best is here, right? White, painless plaques, right? Hairy leukoplakia, right? She has a CD4 count of 200, so likely that it's EBV. Make sense?
Yes. Yeah, that makes sense.